and it starts with all these things. I don't know, I hope you're seeing it from here, but I'm going to be saying it out aloud. So it starts with referral and informants and all those things. Now, this is when you're reporting the history, when you're documenting it, this is how you're going to report it. I have written it out in this manner so that when you're documenting the history, it should flow like this. It does not necessarily mean that when you're taking the history, it should flow like this, however. But if you're able to like kind of take the history in this order, fine. But when documenting it, even if you do not take the history in this order, try to document it in this order. That is more standard, and that's going to allow you to interact with any other clinician in the future, and any other doctor that takes your clerking or the patient's case note, and he sees this clerking, he'll be able to flow. So this is how how it should be arranged. So you start with trying to look at referral notes. Is there any referral notes? If there are, where are they from? Is it from a fellow doctor? Is it from a private hospital? Is it from the police department? Is it from prison? Where is this referral letter or the referral note coming from? Then you also want to know the reason for the referral. Is it that this person has been managed in a particular peripheral hospital and that he has not been responding to treatment, or maybe he's treatment resistant? Now the person is referring him to you for you to give additional expert management. Or is it that the person is being managed maybe for a medical disorder by a general practitioner, and the medical practitioner feels he needs to refer him to a psychiatrist? Or whatever the reason is, please document the reason for the referral after you mention where the referral is coming from. So next, you want to know if there are informants, So are there informants? There are times actually in psychiatry when the person in fact may not even be able to give you any information. So most of the information you're going to have is actually going to be from the informant. So who is this informant, if there are? So sometimes the person might not be able to give you any information. Maybe they are confused. Maybe they have a demented illness. Maybe they are mute because of schizophrenia, catatonia, or maybe they are mute because they have severe depression with psychomotor retardation. And so most of the information you're going to be getting is actually going to be from an informant. Or there are times when this patient is a minor and the relative is the one who is going to give you the information. And if there are informants, who are these informants? Are they family members? Are they the spouse of the patient? Are they co-workers? Is it the police? Is it maybe somebody from prison who brings him, maybe there's a forensic psychiatric issue involved? So you want to know who the informant is, and you want to know if it's a family member, for instance, you want to know how close he is to the patient. If it's not a relative, maybe you may not know for how long has he known the patient. That's going to tell you how important or the reliability of the information is going to give you. So you want to establish that. When you're done with all that, you now at the bottom document what you think of the reliability of the information. Like, do you think this information is reliable? And this is your own judgment to make. Now, another importance of documenting the reliability or otherwise of the information is that if you think the information is not very reliable, you can now arrange for subsequent consultations with other family members or with other people who you think would know him better. And that's why additional thing that I need to point out here is that in psychiatry, history taking does not start and finish in one sitting. History can be taken continuously. You might, however, need to take the first initial history to have a working diagnosis, to commence on certain treatments, so that you begin to relieve the distress that this patient has. But history can be an ongoing thing. So this is it about informants. Now you're done with that. You've documented that in that order. The next thing, as in other specialties of medicine, is to know this patient. So you want to know about his biodata. So the biodata starts from his name. So there's this mnemonic Nastroma that you can use. So, and you probably have your own mnemonic too that you can use, but essentially it captures this information. So you want to know his name, right? You do not want to be referring him to X, Y, or Z. You want to be referring him to his own name, and that's very important. So the next thing is the age. How old is this guy? The S is his sex or gender, right? The T is for his tribe. In Africa, we use tribe or ethnicity. It's better to maybe use ethnicity or race of the person. Then the R is his religion. What religion does he practice is important. Then the O is his occupation. If he's unemployed, you should mention it here, right? So marital status is the M, and then the A is the address. Where does he reside? Bare basic or the bare minimum about this person or the biodata of this person that you need to establish in history taking. So you get that information and you document it. There are times when this system information may have been written written already on the case file of the person. So, but you need to cross-check to know all these things and fill in any of the blanks or any of the places where this information is not recorded. So you've gotten the biodata of the patient. The next thing you want to get is his presenting or chief complaint. Now, the presenting complaint is are the most important symptoms that the patient presents with. So these chief complaints should be differentiated as much as possible from some of the complications of the illness that he comes with. So for instance, if the person has psychotic symptoms and because of that his work has been affected and maybe he dropped out of school, and when they come, maybe they will give you all those things as their presenting complaints, or their relatives will tell you all those things. So as much as possible, mostly because of your knowledge of psychiatry and of your knowledge of medicine generally, you try to select only the important symptoms that you're going to put as your chief complaints or the presenting complaints, and you elaborate on all the other issues that he has in the body of the history, which we're going to talk about next. So the presenting complaint or the chief complaints are those important symptoms that would help you in making diagnosis. And this is not to say that you're not going to talk about other things in the body of the history, but these are the most important ones. Usually you itemize the presenting complaints, usually 3, maybe maximum not more than 5. And so you itemize them and then you put the duration of each of the symptoms. Usually they should be written chronologically, starting from the one that started first to the most recent symptom. So you itemize them, and this is how you're going to write your presenting complaint. And as you can imagine, this is what you do in other specialties of medicine. So the next thing is you're going to go to the 5th item on history taken in psychiatry, which is the body of the history. In other specialties of medicine, this is also called history of presenting complaint, and this is also a term that is used even in psychiatry. So the history of presenting complaint is what comes next after the presenting complaint. So what are the things that you're going to be looking out for when you're taking history of presenting complaint? The first thing, or one of the first few things you want to find out, is the onset of this illness. So what was the nature of the onset? You already know the duration, right? So but when it was starting, was it an acute onset or was it a condition that was of insidious onset? So it was gradually happening. So, and how you know that is from the time that he was completely fine to the time that he completely became ill. What was the period? What was the time duration? So that allows you to know the nature of the onset of the condition. So if from the time he was completely fine to the time that he was fully ill was just maybe a matter of few minutes to few hours to maybe few days, you know that you're talking about an acute condition, an acute onset condition, right? Or in fact, it might even be an abrupt onset depending upon the condition. There are such terminology that might be used maybe when you're talking about acute and transient psychotic disorders, when you can say that the onset is even abrupt onset if it is ultra short duration from the time he was fine to the time he became ill. So these are some of the things that you want to know in the nature of the onset. Then the next thing is you want to know the cause of the illness. How has it progressed from that time that he became ill to the time that you're seeing him? How has it progressed? Is it a condition that has had a flat trajectory in which he just had the condition, the symptoms are there, and they remained the same? They didn't worsen and they didn't improve. So when you're talking about the cause, you want to know over time, how has the condition progressed? So some people will tell you, well, there are times when they get better, and if they have gotten better for any reason, you want to know those reasons, or you want to know those periods of time when they are better. So for an example, people who have depression tend to have diurnal variation of their mood, in which the mood is most severest in the morning and it tends to somehow improve as the day goes by, right? So you want to know all those kind of changes, and so you want to know, and not just in a day, not just diurnal variation, you want to know progression of the symptoms and of the condition over the period in which he has had the illness. Then next, like we said, you want to know the duration. For how long has he had this condition? For how long has he had this illness? You get to know that and you document it. And of course, you've already also noted it at the time you were taking the presenting complaints. So the next thing when you're done with that is under history of presenting complaint is to know the nature of the symptoms. So this is where you actually sit down and delve deeper into each and every one of the symptoms, because here you want to know the psychopathology that is going on with this guy. As it has been said by some authorities, when you're taking history, you begin with a certain hypothesis in the back of your mind based on some of the symptoms that you got at the beginning of the history. So, okay, this and this and this are the combination of symptoms here, so probably he has this disorder. Now, as you're getting more history, as some information are becoming available to you, you're not kind of, okay, well, it might not be what I thought, it is this disorder. So it is a kind of ever dynamic process, and you tend to modify your hypothesis based on the information that continuously become available to you. So, and you get to do that because you're eliciting information that helps you to establish the nature of the symptoms that this guy comes with. Now, you look at each of the symptoms that he presented with, and when you are done with that, you go ahead to try to elicit for other symptoms that you know should be or should not be associated with this condition based on the hypothesis that you have in mind. So if it is a mood disorder, you want to know, okay, he did not tell me that he had these and these symptoms in the presenting complaint, but are these and these symptoms there? So you elicit for those symptoms. Now, if they're there, you get to know that they're there, you establish them, and you document them. Now, the ones that are not there are the so-called important negatives, and I've written it here. So there are some symptoms that you expect maybe for any disorder, right? Maybe for mood disorders, maybe depression or bipolar, there are symptoms that you expect. And if they're not there, they are important negatives, and you write them here. And again, in other specialties of medicine, we do the same thing here. So somebody who presents you with a syndrome in keeping with congestive cardiac failure, you expect some certain symptoms, right? So the ones that are not there, they are important negatives, and you document them. So the same thing applies in psychiatry too. So important negatives. So this is all in a bit to understand the nature of the symptoms he came with, so that you understand all the symptoms he has, so that at the end of the day, it helps you to draw a picture that helps in making diagnosis. So you've done that. The next thing under history of presenting complaint is to know whether there are any coping mechanisms. He has this disorder that has been there for this long, and these are the symptoms that he has, these are the symptoms that he doesn't have. And so how has he been managing? How has he been coping? The symptoms, are they making him to do a number of things? Or are they making him to avoid a number of things, all in a bid to cope with the symptoms or to cope with the condition that he has overall? For instance, we know that people who have anxiety disorders tend to cope, albeit in a maladaptive manner, by avoiding the situations, especially if they are phobic anxiety disorders. So that is a coping mechanism, but a non or a maladaptive coping mechanism. So you want to know all those things. Also, people who have post-traumatic stress disorder also tend to have avoidance. So all these are coping mechanisms. Or some people tend to pray a lot. Or patients with OCD might think that they are having those intrusive, distressing thoughts because maybe they are morally weak, or maybe they're not religious enough, and maybe that might make them to be prayerful in a bid to see how they can prevent or how they can somehow cope with the symptoms. So getting the coping skills or the coping mechanisms that the patient has been employing since this condition started is an important part of the body of the history. Next, you want to know whether there are in fact any stressors. So here you are kind of trying to go to the place where you want to establish history of etiological factors, so to speak. And we know that stressors, especially negative life events, are important triggers or precipitating factors in the onset of many psychiatric illnesses. So here you want to know whether there are any stressors. Now, when you want to do that, you want to know if these stressors have any temporal relationship with the onset of this condition, because if there is no significant temporal relationship, maybe this is just a coincidence. If the person has had a certain illness, or if the person has had a certain psychosocial stressor, like more than 2, 3, 4 years ago, and now he's breaking down with a maybe psychotic episode, you know that this is not at all related. So temporal relationship is very important when you're looking at any triggers or any stressors. Additionally, these triggers might maybe be the onset of medical conditions. Maybe the person has just been diagnosed with a very serious medical illness. So you want to know the temporal relationship again between the onset of the medical condition and this psychiatric illness that you're clerking him for. So you've done that. The next thing you want to do is to look at whether there are any functional impairments. In psychiatry, one of the things that tell us that the illness is severe enough is if there are functional impairments. Functional impairments are issues or difficulties to do with the person's inability to go about his normal day-to-day activities, and they include a number of areas of one's life. So they include personal functioning, occupational functioning, they include family and social functioning, and they also include academic and any other important areas of functioning for that matter. So if any of these areas are affected, whether personal functioning, and so personal functioning include your ability to take care of yourself, right? When you wake up, you want to bathe yourself, you want to clean your teeth for your dental hygiene, you want to dress yourself up, and when you come back from work, you want to maybe change your clothes, you want to dress yourself, you want to wash your clothes if they're dirty, you want to feed yourself. So all these are normal personal functioning that we sometimes take for granted, but that may be affected if we develop some psychiatric illnesses. So that is personal functioning. Occupational function is your ability to go and work, but fruitfully and productively. There are times when you may be able to go to work, but you're not productive, right? So you're working, but you're not productive, right? There are times when you have some psychological or mental illnesses and they affect the occupational functioning. Family functioning is to do with the relationship with your family, your wife, your spouse, and other people in your family, how you relate with them, how you go along with everybody. Some mental illnesses give some difficulties with family functioning. Social functioning, your general social activities. So in essence, these are the areas of functioning that we look at when we look at functional impairment. So, and it is a very important thing. And in fact, these are some of the things that help us know how serious the mental illness that you have is. So when we look at that, the next thing in the body of the history that we are interested in is history of treatment. Now, since this condition started, this patient, has he ever resorted to looking for any form of treatment? And this treatment, is it conventional or unorthodox treatments? Especially in Africa, we see patients who look for treatment in many unorthodox settings. You know, our patients patronize traditional healers, our patients patronize faith-based healers and all that. So we want to know whether he has sought for any treatment, and if yes, what is the method of the treatment. The reason why we are interested in this is because some of the treatments might be detrimental even to the health and even life sometimes of the patient without necessarily bringing about any improvement. So that's why we want to know whether he has had any treatments and whether it is conventional or unorthodox. If it is conventional, we want to know whether the treatment has been helpful and where did he receive this treatment? Was it in a hospital or maybe in some certain peripheral places? And was the treatment effective? Were there side effects? How did he respond to the treatment and all those things? We want to know this. And if they are helping him, we want to know maybe the particular type of medications, or if it is not medication, if it is therapy, we want to know which therapies he has done. And in discussing history of treatment, you also want to know maybe there were investigations done or there were investigations that you would have thought would be done but were not done. So these are all part of the history of treatment you want to establish as part of your body of the history or the history of presenting complaint. So you're done with the history of presenting complaint or the body of the history. The next part you're going to go to is the past psychiatric and medical history. So here you're going to detail a lot of the things that have happened to your patient before this time that he's seen you. He must have had some psychiatric illnesses in the past. He must have had some medical conditions in the past. And so you want to know all of those conditions. So you want to look at past psychiatric illnesses. Has he ever had any psychiatric illnesses in the past? So this is what you want to answer. You want to know whether that illness is similar or is dissimilar from this index presentation or from the condition that brought him to your consultation today. You know that some disorders tend to be recurrent. They tend to come in episodes. And you also know that there is this concept of relapse and then there is this concept of recurrence. So is he coming to you with a relapse of a previous illness, or is he coming to you with a recurrence of a previous illness, or he is simply now coming with a different illness altogether, but nonetheless, knowing what illnesses he has had in the past will still give you a very important picture of who you're dealing with. So you want to know also the treatment he has received or whether he has received any treatment at all. And if he has received any treatment, these treatments, were they orthodox treatments or unorthodox treatments? You also want to know whether the treatments were helpful, whether they were useful in improving the previous mental health condition he has had. And if that's the case, you want to know which type, in fact, what sort of medications, or whether he has had psychotherapy or any type of treatment he has received. If, for instance, you're dealing with a mood disorder, the number of episodes he has had. So if it is bipolar disorder, for instance, you want to know the number of episodes he has had. And maybe you want to even know the number of episodes he has had in a particular period of time. Remember that if you're dealing with rapid cycling bipolar, you want to know the number of episodes he has had in a year, for instance. So and if he has had more than 4 episodes in a year, we are dealing with somebody who is a rapid cycler, and that is going to inform the type of treatment he's going to receive. So you get this history from the past psychiatric history of the patient. Now, you also want to know how they were treated, just like I said, and where they got their treatment from, and then the treatment response, how they responded to treatment, was there improvement, and then you want to know whether there were any side effects, and if there were side effects, those side effects, did they contribute to his poor compliance with treatment? You want to establish all those things so that you can see whether that can mirror in this current index case you're dealing with. Next, you want to look at history of any chronic medical conditions. This person, does he have diabetes mellitus, for instance? Is there a history of a cerebral vascular disease, or does he have cardiovascular diseases? Does he have any malignancies? Is there any chronic medical condition for which he is receiving continuous ongoing treatment? If yes, you want to know what treatments he has been on and whether he has been compliant with those treatments. And you also want to know whether this, in fact, these conditions or their treatment has impacted on this current presentation. So that's why you want to know his past medical history. Also, here you're going to capture whether he has had any surgeries and for what condition. So if he has had malignancies for which he has had surgeries and chemotherapy and all those things, you want to know that kind of information because it might be useful in this case. Additionally, apart from diabetes mellitus, did he have other endocrine conditions? So was there hypo or hyperthyroidism? Was there Addison's disease? Were there any endocrine diseases, especially if he has a condition that makes you want to ask more about his presentation? And that's why I said previously, the extent to which you will go would depend upon your own discretion, depending upon his present presentation. There are times when you just want to ask peripherally on this past psychiatric and medical history, whereas there are other times when you may need to dig deep and know all the past medical history. So when you're done with the past psychiatric and medical history, the next item, which is the 7th item, is family history. You want to know everything about this guy's family. You want to know everything about the parents. You want to know everything about the siblings. You want to know the nature of the family. Is this a monogamous family setting or is this a polygamous family setting? You want to know the number of spouses that the father has, and you want to know the number of children, how many full siblings he has and how many half siblings he has. Again, this will depend upon the culture. In some cultures like Africa, it is not uncommon to find polygamous families with many spouses and many children, some of them full and others half. So you want to know everything about them. So you start with the parents. You want to know everything about the dad and the mom. But importantly, you want to know the age of the parent as at the time you're taking the history. If the parents are led, you want to know the age at which they died and the cause of the illness as much as possible. And you want to know their occupation. You want to know whether they are still working or maybe retired. You want to know their current health condition or their current health status. And you want to know the nature of the relationship that they have with this patient. You want to know whether in these parents there is any significant medical or psychiatric history. Remember, genetics is important here. And in fact, that's why we are even worried about the family history, in addition to other reasons. We want to know whether there is any significant family history of any mental illness. So you start from the parents and you want to document that if it's there. Next, you go to the siblings. Now, each of the siblings, you detail them. You start with the oldest and you mention everything about them, their name, their occupation, their health status, the relationship they have with the patient. And then you continue chronologically until you go to the youngest member of the family. You need to, if it is a polygamous family setting, you need to also mention whether it is a full or a half sibling. You detail everything about each of the siblings. Now, it is here also that you're going to mention the birth order of the patient. Now, when you do that, then in closing, you mention now whether there is any history of psychiatric condition in the family, and if it's there, whether it is similar to that of this your patient or it is dissimilar. This essentially is what you want to talk about in the family history. When you're done with the family history, the next thing you're going to go to is you now calm down on this your patient. Remember, you've mentioned the family, you've talked about everything that you know about the family. Next, you now talk about this guy. And in talking about the patient, you're going to go back as far back as even pre-pregnancy period, the time even before he was conceived. And here, you're going to talk about whether his pregnancy was intended, whether it is a wanted pregnancy, whether it is a planned pregnancy. So you mention whether it is intended, whether it is wanted or whether it is a planned pregnancy. There are pregnancies that may be wanted but unplanned, and it is important because the attitude of the parents to a pregnancy that is unwanted might be different from a pregnancy that is desperately wanted, for instance. And here we're not even talking about whether this pregnancy is legitimate or not, whether it was gotten, whether the pregnancy was conceived in or out of wedlock. We're not even talking about that. We're just talking about whether, even in normal traditional family setting, whether this pregnancy was planned for or not, whether it is wanted or not. So this is as far back as you can probably go back to. However, it is at your discretion to dip into this history depending upon the condition or the presentation. Of course, you're going to deal a lot with these early personal histories if you're dealing with a developmental disorder. That's when you are interested in the pre-pregnancy and the pregnancy period. So in the pregnancy period, you want to know how the mother has been faring during the time that she was pregnant with this your patient. Was she having illnesses? And particularly, you're worried about febrile illnesses. So, but it is at your discretion. There are times when this is not, these details is not necessary. Maybe a 45-year-old guy coming to you with first episode psychosis, and maybe it is not important to detail all these things. But if you're dealing with maybe somebody, a child or a young adolescent who has a neurodevelopmental disorder, perhaps you need to detail all these things. Now, in the perinatal period, also there are histories of importance that you need to elicit and document. So, in the perinatal period, in the peri-pregnancy period, how was the labor like? How was the delivery like? And after the delivery, how was the mother faring and how was the child faring? So, if there is postpartum hemorrhage, for instance, the child may be okay, but you know that this is a risk factor for having maybe perinatal asphyxia. So, and so history of perinatal asphyxia is important. It should be elicited and documented. And history of neonatal jaundice is important and it should be elicited and documented. So these are some of the perinatal histories of importance that you need to mention and document in your history. The next is you want to know something about the early developmental milestones of this your patient. So here, developmental milestones essentially tell us how fast the brain of the child was growing. So if there's a significant delay in the maturity of this child, especially in achieving developmental milestones that are significantly different from what the mother has for her other children, then this tells you that, yeah, these developmental milestones are really delayed. So, and which developmental milestones are you interested in? You want to know when he started, when he walked, when he talked, and you want to know also when he achieved sphincteric control, essentially when he became continent. So these are histories that are important, and if there were any delays, you should note that and you should document it, and it is an important history. The next thing is the childhood history. Now, in the childhood history, you want to know, was it an enjoyable childhood? Was it a childhood that he enjoyed a lot of play activities, that it was essentially a normal, enjoyable childhood? And if yes, you document that. Also, were there any deviations, such as separation from his parents, and for how long, and what was his reaction to that separation? You also want to know what his emotional, whether he has had any emotional problems, in childhood. So, and this is important because emotional problems in childhood can usually continue and carry over into adulthood. A lot of childhood disorders actually can be carried into the adulthood. So you want to know whether he has had any emotional problems. If there are, you want to document them. Then whether he has had any serious illnesses. Children who have been frail, patients who were frail when they were children and who had a lot of medical problems are more likely to have some psychological issues. Because, okay, for instance, a child who has had serious chronic medical conditions that the parents have been maybe battling with is a child who, maybe because of the enormous burden he may place on the parents, maybe might even be abused or something. So these are all the things that you want to be looking out for. And like I said again, the details or the extent to which you go in eliciting this would depend upon the context in which you're seeing the patient. So when you're done with that, next, after childhood, of course, he will reach school age and he will start school. So you will now want to know his educational history. Educational history here, you're going to document his educational achievement. How has he been faring in school? Has he been performing excellently? Is he an average, below average, or above average student? If he has taken any standard examinations, you want to know how he performed, and you might want to compare that with the national average, especially if you're dealing with somebody who has a developmental, especially neurodevelopmental disorder or intellectual developmental disorder. You want to know how he has been achieving all those things. And then in school, also under educational history, you want to know how he has been engaging or whether he has been engaging in any extracurricular activities. That is going to be important history. And then how was his performance, and then to what extent did he excel in extracurricular activities. That will tell you how matured he is and how functional he was, kind of how whether he was a functioning young man at that time. When you're done with that, you want to know also the kind of relationship he has had with students, fellow students. And you also want to know the relationship he has had with teachers generally. And again, that's going to tell you something about how his personality was developing at that time, how his temperament, and later how his personality was developing. And that is an important history. Then again, under educational history, you want to know whether this guy has been a victim of bullying in school, whether he was bullied, and you want to know the nature of the bullying and for how long he was bullied. Or you may also want to know, was this guy the bully himself? So again, children who have had maybe conduct disorders as children would be the bullies themselves. And during childhood and during school, all these things will come up. And so you want to know whether, in addition to maybe being a bully, whether he was a truant, and or whether they were engaging in other dissocial or deviant behaviors in school, like being cruel to animals or being mean to other students and what have you. So when you get all this history, that will point to somebody who may have had a conduct issue, even if not full-blown conduct disorder, and then that will give you idea as to, as an adult, whether he has continued to have an antisocial personality. So these are histories that you want to elicit, and they can come under childhood and educational history. Now, when you're done with that, you want to go to the psychosexual development of this guy. So you start from psychosexual development, is essentially telling you how he matures into being an adult. So at what age did he achieve puberty? What age did she reach menarche, for instance, if she's a lady? And then you also want to elicit the history that suggests the age they achieved coitarchy. That's the age when they had their first coitus. And you also want to know whether they've had any STDs and whether they generally know how to protect themselves against STDs and what have you. And you want to know, again, under psychosexual development or history of psychosexual development, what their sexual orientation is, and what have you. So when you get this history, you're done with that. So you go to the next part of the personal history, which is occupational history. Under occupational history, you want to know the number of jobs he has had, and then you want to know everything about his current job. What are his duties? What are his responsibilities? How is he performing? And is he satisfied with his job or not? Then you want to know all the previous jobs, everything about the previous jobs, the dates, the number of jobs he has changed, and reasons for changing if he has changed so many jobs. And if this guy has changed so many jobs, you want to know, is there something wrong with him? Why is he changing jobs? Is he having difficulty coping? Is it a capacity thing, or is it a personality thing, or is it an emotional thing? So again, this is something that will have a telling effect and might even help you to understand him better if you get this history. So the next thing is history of significant relationships. Again, still under personal history. Significant relationships include relationships he has had usually essentially with the opposite sex. If she's a lady, how many men did she go out with, or currently who is she going out with, or is she married or is he married? Who is the wife? What is the nature of the relationship? How close is it? And then maybe what is the health status, occupation of the spouse, to tell you how stable he might be. Because of course, if the spouse is not healthy and the relationship is not deep and stable, you know that this guy might also have issues to do with that. So you want to know everything about this relationship, and then you go back also to look at any previous relationship he has had. And then you want to know whether this relationship whether they are married or they are just cohabiting but not married, and you document this history as much as possible. The next thing is whether he has any children or not. If he has children, how many of them, what are their names, what is their health status, how are they doing generally. If they have health challenges, you know that might be an issue for this your patient. And maybe that might even be either a perpetuating factor or even a precipitating factor for him or her presenting to your consulting room. So that's why you want to know everything about the children. So the next, you want to know the current social circumstances of this your patient. Current social circumstances essentially details two things. Essentially their accommodation, the nature of how they live, and then you want to know something about their finances. So their accommodation, are they living in their own house or are they living in a rented accommodation? And if it is a rental accommodation, are they able to pay their rent, or they are even owing? So you want to know all these things. So financially, you want to know. Also concerning the accommodation, you want to know the composition of the household. who does he stay with? Who are the members of the family? Or who is he staying with? If he's a 29-year-old or 35-year-old guy who's still staying with his mom in a single bedroom and he sleeps in the parlor, it's different from somebody who is 35 and he has his own house, and again different from somebody who is 25 and he's renting but he's stable. How comfortable is he in that house? What is the level of privacy if there are many in the house? Kind of. So this is to tell you about the current social circumstances. Then the finances. Is he financially stable? Does he have a stable job that gives him steady income? These are all the things that you want to document under his finances. Or he's somebody who is always broke, who is always in debt. And if that is the case, you want to know why. Again, there are people who are into maybe drugs, and therefore, although they have a normal job that pays a good salary, but they are always in debt. So this is going to raise some red flags for you that will make you dig deep and try to understand what is going on. So the next thing after that current social circumstances is to talk about drug history. Now, drug history, some people think maybe it should be separated from the personal history. So drug and the subsequent forensic history, some people believe maybe it should not be part of personal history, but again, you're talking about this guy, so it's about his life. You're talking about whether he has done drugs or not. So the drug history, essentially you want to look at alcohol, tobacco, and illicit substances, whether he uses any of those things, and how much does he use it, if he uses it, and what is the duration, for how long has he been using it, and how much does he spend on any of these substances. And you also want to know whether there are any effects, whether there are any negative effects of the use of any of these substances. So for instance, is it already eating into his finances? Is it already eating into even causing him health and psychological and emotional and occupational problems? This is where you detail all these things. So this drug history, however, at times, if the presenting complaints include the use of any psychoactive substances, or the presentation was any problems from the use of psychoactive substances, naturally these complaints would automatically come and be part of the presenting complaint, and therefore you would detail everything about the use of the substance, the nature of the use, the type of substances, the duration, the problems associated, and what problems result from the use and all that. You detail them in the history or presenting complaint or the body of the history. But since this thing is not probably an issue, you didn't talk about it until when you came to the personal history, where you are now going to mention everything about the drug history. And at times, it's even possible that the person is using some substances, but that is not even a problem, or it has not come to light that is a problem. So this is an opportunity for you to actually bring it to the fore so that it can be discussed properly. Okay, so the next aspect of the personal history is to go to the forensic history. Now, in the forensic history, you want to know history of arrests and for what offenses. You want to know how many times he's been arrested, and you want to know whether any of those arrests has led to a conviction and whether he has been incarcerated as a result of that. And you want to know the number of times he has been so incarcerated. So that's going to tell you, kind of help you build a profile of this your patient. All right, so once you're done with that, you're done essentially with the personal history. The next aspect, which is supposed to be the final component of the history in psychiatry history taking, is the premorbid personality. The premorbid personality is a history that sometimes the patient can give you an idea, but you can get that a lot from people who know them. Maybe they are family members, maybe they are parents, maybe they're very close friends that have known them for long. You can get a lot of that history from those people. And traditionally, we obtain premorbid personality under these headings: relationships or friendships, use of leisure activities or use of leisure, predominant mood or emotions, and character and attitude. So relationships or friendships, here you want to know whether this guy has a lot of friends, or he is somebody or she is somebody who has only very few friends. And you want to know whether friendships are things that they take seriously or things that they do not take seriously at all. And you want to know how close the relationships that they keep are. So if they have friends, how close are those friends to them? Also, you want to know something about the kind of friends they actually keep. So here, when we talk about relationships or friends, we're talking about maybe friends in their general life, general social life, not maybe the friends that they keep maybe to do in relationships, like significant relationship that we mentioned under the personal history. Here, we're talking about maybe friends generally, social activities, friends that they keep as friends, not as opposite sex kind of relationships. So next, you want to look at how they use their leisure time. So what are their leisure activities? So here you're going to be talking about their interest, you're going to be talking about their hobbies. So how do they spend their leisure periods? Are they the people that go to library and be reading books? Or are they the people that go and do outdoor activities, like they'll go and be gardening, or they'll just go and maybe play some certain games. So essentially, how do they spend their leisure activities is something that also tells you something about them. The next thing is their predominant mood or emotions. So here you want to know something about how their emotions are over a long period of time. So are they people who are known to be very cheerful? There are people, once you think of them, you know that, oh no, this guy is always cheerful. There are people, when you think of them, you know, oh no, this guy is always anxious. There are people, when you look at them, ah no, this guy is always overconfident. Oh no, this guy is always over optimistic. Oh no, this guy is a pessimistic guy. So all those kind of things are the predominant moods that we want to know about this patient. And then these moods, are they stable over time, or is he somebody who is emotionally unstable, in which maybe his feelings or his emotions tend to fluctuate over time? Again, this is something that tells you a lot about this patient. Also, is he somebody who is controlled, or is he somebody who is over demonstrative kind of? So again, these are things that will tell you something about this patient. So the next thing is to look at the character. And when we say character, we are talking about character traits like maybe whether they are obsessional, maybe whether they are paranoid, maybe whether they have any perfectionist tendencies. So these are all the things that we're talking about when we mention character here. So, and then, or whether they are controlling, or what kind of people are they when you look at all those things. There are people that the moment you think about them, what comes to your mind is that, no, this guy is too meticulous, therefore he may have obsessional tendencies and all that. There are people, when you think about them, this guy is somebody who is always very secretive, almost always paranoid and all that. So these are where you record under the character. This is where you record all these kind of things. Now the attitude here is the final thing that you should look at in your patient. So what is his attitude to maybe politics? What is his attitude to religion and morals? What is his attitude to contemporary issues? Is he the type that has maybe a nonchalant attitude towards maybe politics, but if it comes to maybe sports, he is very active? So what is his attitude to morals and religion? We see the type that is also nonchalant when it comes to religion, but when it comes to politics, is very active. So you want to know all those things about this guy. These are things that helps you build a personality profile of this guy, and that helps you to understand him very well. So by the time you're done with the premorbid personality, you would have succeeded in completing history taking in psychiatry. And like I said in the beginning, you should take the history in whatever manner you want, in whatever fashion or whatever order you want, but by all means, try to adhere to this order of arrangement, starting at the top of your documentation with your referral, informants, your biodata, your presenting complaint, history of presenting complaint, then you go to past psychiatric and medical history, then you go to family, personal, and conclude with premorbid personality. So that way you have followed a conventional way of documenting history, and when you're presenting the history, you should also present it in this format. See you some other time.